right. Welcome, welcome. Welcome, everyone. Tell us where you're joining us from in the chat. Don't forget to select everyone if you write something in the chat. Just going to give it another few seconds and then we'll get right into it. All right. Okay. Well, hello, everyone, and welcome to our webinar, What to Expect After Breast Cancer Reconstruction Surgery. I am Megan Claire Chase. I'm the Breast Cancer Program Director here at SHARE, and I'm also a breast cancer survivor. Before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. Now, we have a few housekeeping reminders for you. All participants will be muted during the presentation, but feel free to engage in the chat. Once our fabulous speaker finishes presenting, we'll begin the Q&A discussion. So feel free to ask any questions through the Q&A section at the bottom of your screen. Remember that Dr. Levine is unable to give specific medical advice, so keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. This webinar is being recorded, and we will share this recording in a few weeks with all registrants, and it'll be added to our website. So now I'd like to hand it over to Dr. Levine to introduce himself. Dr. Levine, the screen is yours.
Thank you. It's an honor to be here. This is an amazing organization. I think I've been involved with talks in the past with some of my colleagues, and I think it's a huge help for people to understand what their options are surgically. I'm a reconstructive plastic surgeon. I've been in practice for well over 20 plus years. I'm the chief of microsurgery at NYU. So I've moved tissues around the body for different reasons, but mainly a large portion of it is for oncologic reasons. I've been performing breast reconstructive surgery for over 25 years. So I've seen the changes that have occurred in it, and I've seen also the changes that have occurred, even legislation for it. I'm a strong believer in breast reconstruction. I'm not a zealot for one specific type of breast reconstruction. I think it's a very patient-specific thing, and it's important, and that's what we're going to talk about here, to have an understanding of what's available for you and what your options are. I think it's most important that you understand your options, and I think it's the right of every patient going through this to have that ability and have that discussion. So from here, I think we should just try to begin and go over what's available to you. So I'm going to bring up my talk, hopefully. And it's great to be live. And for all those that, see this afterwards, I think it's useful to just get information and data if you're faced with this, and not necessarily just to listen to what one person's opinion is. People, and I always tell this to my own patients, if you talk to someone, if they've had a good experience with something, they're going to be very sort of forceful or desire you to go through what they went through. If they've had a bad experience, they'll, going to sort of push away from that. But you really have to listen to all the information yourself so you can make the right decision, because all forms of breast reconstruction can work. It's just what works right for you. So here we go. In mastectomy reconstruction, oh, sorry. I think the first major decision, this is when a patient comes into my office, is deciding whether or not to just proceed with breast reconstruction. I think that's the first choice. And I think that's a very important part. Even the choice to not have a breast reconstruction is important. As long as the person has knowledge and understands what's available, I think then we've done our job in giving information and education. But there's multiple pathways, and that's what we're going to discuss. And no matter what the process is, the main objective is to achieve an appropriate and aesthetic breast reconstruction for the patient. When I started in practice, actually, I think the numbers were lower than this, but I was going through, I think only really 8% or less of the eligible patients that were getting breast mastectomy were actually getting reconstruction. I've seen those numbers increase, and looking through the literature from 2009 to 2014, the amount of breast reconstruction actually rose 62%. And by 2016, 40% of patients were getting reconstruction. Certainly, it's much more now. The types of reconstructions have changed. We'll get into that a little bit. When I also started out, it was very rare that people use their own tissue to do that, but it's become much more popularized and is certainly a major part of breast reconstruction, as well as implants. So we're going to talk about, to me, how I present it to my patients is really three main directions. It's two, but the third one is a combination. So there's autologous, or using your own tissue. There's implants, which is basically, either a 1 or 2 stage process, and that's a device that's sort of in a box we open up, and then we utilize that for the reconstruction. And then it's a combination using some of your own tissue and implants. And then there could be staging of this. It takes on nuances based off of the type of mastectomy that the patient's going to be going through. It takes on nuances, whether it's unilateral or bilateral. So there's all sorts of things that need to be understood or discussed prior to going through this to help the person make the decisions that they need to make. But as long as you're with a, sort of a capable and I'd say well-experienced breast reconstructive surgeon, all of those hurdles could be jumped over, and you should be able to obtain a very aesthetic and otherwise good appearing breast reconstruction. So using your own tissue, I'm just sorry, I'm just getting in my own way, forgive me. It's individualized to the patient. And again, that's how I look at it. It should be not necessarily what I want to do, not necessarily what I feel most comfortable with. Let's say I just do it part-time and I only do implants. It should not necessarily be that every patient gets an implant reconstruction. The same goes with using your own tissue. I think the person who's coming in for the mastectomy and the reconstruction should be choosing what's best for them. So it's important to know what your options are and sort of what the pluses and minuses of each of them are, so you can understand that and make the right decision for yourself. And when that decision is made, it's the right decision. And, there are options for, let's say, if you don't choose to do reconstruction, you can come back and do reconstruction later. If, let's say, you choose to do an implant reconstruction, but then you want to transfer and change to using your own tissue, that could also be done. So there's a lot of flexibility within this. So you should know that all of that's available for you when trying to go through this hard decision. And when patients come into my office, they have gotten diagnosed oftentimes with cancer, and they're trying to understand and deal with that. And then they're being sent into a plastic surgeon to discuss reconstruction, and it can be overwhelming. So if you could have information, you could sort of sit on it a little bit. It helps you to make a decision that will work best for you. So different techniques to create this. There's using implants, which you see faced on the left in this drawing. On the right side is a variant of what's called a tram flap, which is a transverse rectus abdominis myocutaneous flap. in that setting, we're actually rotating muscle up with us. There's different variants. The one I perform mostly now is with what's called a free flap and a perforator flap, where we're actually not taking any muscle, but we'll show some different variants of that. So autologous tissue, that's using your own tissue to do the reconstruction. Most patients, it'll come from the lower stomach, the area, and I try not to tell patients to think of it this way, but where they're going to have like if they were coming in for a tummy tuck, it's the same lower abdominal tissue. But I wouldn't tell someone to do it just to get the tummy tuck, but it is a secondary gain sometimes. But that tissue is what we use to provide for the reconstruction, because it's often tissue that's of excess. But there are other locations. You could use the back, the thighs, even the buttock to do these reconstructions. And in this setting, no artificial materials are utilized. So the TRAM, or the transverse rectus abdominis myocutaneous flap, that's where you take the tissue from the lower abdomen, and you have to keep this tissue alive. So we do that by rotating it up and taking one of the muscles of the abdomen called the rectus abdominis muscle. And that's what provides a source of blood supply for it. And this is just a descriptive drawing showing the movement of that tissue and its attachment to the abdomen. The pedicle TRAM was, when it came out, was a game changer for reconstruction and really set a new hurdle in providing patients with a soft autologous option for breast reconstruction. But one of the downsides of it was that you were sort of doing more surgery on the abdomen, taking a muscle from there, and it had risks of hernias, or what we call bulging, due to the separation from that muscle. But still, it was a huge leap in breast reconstruction when that was when they came up with that. And this is just a picture of a patient who underwent pedicle TRAM and ultimately a nipple reconstruction. And this is right after nipple areolar tattooing. So you can see it can provide a very good reconstruction for a patient, especially for a unilateral defect. The free TRAM is another variant of this, and that means that we're now changing where we're taking the blood supply from. We're taking a more direct blood supply that's going lower and directly into the tissue. But here we're also still taking a little piece of muscle with us. And this is just a representation from artist depiction. And here's a patient who had that procedure with a muscle based free TRAM flap. Nowadays, the majority of what I do are called perforator flaps. And what does that mean? It's still the same circulation. It's the main circulation that goes up into the tissue of the lower abdomen, but we're really not taking any muscle with us. We actually separate the muscle and separate what's called the fascia, which is what holds us together essentially, and just take the blood supply out. It's a little bit more tedious, but I think it offers a better and more functional reconstruction also for the abdominal wall, because you're really not taking anything but really fat, some skin that most people don't want anyway, and then the blood supply that goes directly into that region. So that's what's called a deep flap, a deep inferior epigastric perforator free flap. So if you ever hear that term, that's what it is. So it's nothing magical, but it's a very specific term that's based towards that type of tissue and that type of reconstruction. There's also a lot of other terms that we utilize, but they all stand for something. They all stand for blood supply and region. So there's PAP flap, which we'll show you. That's profundal artery perforator. That's from the medial thigh. There's lateral thigh arterial perforator flap. So coming from the upper lateral thigh, superficial inferior epigastric flap. There's SCAP, or superior gluteal artery perforator flap. So all different locations coming from different places. So I described basically just taking the tissue from the lower abdomen. And I think it's always helpful to see pictures, especially to understand what it's used for and what can be done with it. Here's a patient who is undergoing bilateral, what's called skin sparing mastectomies, meaning that the nipple areolar is not being saved. And that could be for a number of reasons, either because of the type of breast, and the inability to save the nipple areola complex, or that the cancer or breast disease is close or involving in the nipple region. So this patient was going to undergo bilateral skin sparing, and this is just the reconstruction using deep inferior epigastric perforator free flaps, one on each side. So one half of the tissue that was taken from the lower abdomen from one side is put to one side, and the same on the other. And you can see the incision in the lower abdomen, which has healed well and gave a good reconstruction for this patient. Ultimately, they went on to nipple reconstruction, which is another discussion, but patient could go on to nipple reconstruction, meaning creation of a nipple-like structure from the skin that's surrounding that area. And then we usually tattoo around that space to give the coloration similar to the areola. And you'll see this in various pictures. Or patient nowadays, there's great expertise in tattooing, and they could get what's called three-dimensional tattoos, and gives an appearance of three-dimensional nipple areola complex. Here's another patient, a little larger breasted. You can see the bruising from the biopsy on the left side, and they strongly desired using their own tissue, and they had a little bit of lower pannus, which actually was excellent in providing the appropriate tissue for the reconstruction. And you can see this is bilateral skin sparing mastectomies with bilateral deep inferior epigastric free flaps, which I think has given a very good reconstruction with good texture, very breast-like appearance and feel, and I'd say secondary gain of loss of the undesired excess tissue in the lower abdomen. This is another patient who's going through skin sparing mastectomies. Similar, again, just sort of different sizings, different appearance, different types of breasts, but yet this could provide the tissue that is needed or desired for the reconstruction. And this patient did very well with this and had a good outcome in the abdomen, and actually ultimately desired to be a little bit smaller. So we went back, and once the tissue's there, I treat it like a regular breast, and was able to do a breast reduction to this patient, and ultimately nipple areola creation and tattooing. Here's a patient that skin sparing mastectomy. And again, this is for one side, just so you could see how we would try to balance the breast. And sometimes I do need to operate on the other side to try to lift the breast, or the patient may come in and say, I'd like to have both breasts lifted, but one side is going to be the operative side. So we tend to stage those so that we could get the best outcome possible. So I'll do the breast reconstruction on one side, then do the breast lift on the other side. And it's very similar when I do implant-based reconstruction. So here again, patient with right-sided breast cancer. You can see the bruising from the biopsy, so pretty recent from there. And she wanted to try to match the breast as best possible. She didn't have an overwhelmingly large abdomen, but we were able to get enough tissue from there to give really a very nice sort of almost one-to-one match to the other side. And from there, she ultimately did go through nipple areolar reconstruction, tattooing, and nipple creation. So you could see the shape is fairly similar. She had a very small wound at the bottom, which healed in on its own. And I was able to revise that when taking her back for nipple reconstruction. But you could see it could give a very, I'd say, aesthetic and very natural appearance. She really did not want to operate on the other side, but I certainly could have lifted her breast on the other side and balanced her if she desired that. Here's a patient who undergoing breast mastectomies. She had this done in an outside facility. At that point, they felt comfortable to put in tissue expanders, but she really wanted to utilize her own tissue. Her issue is that she's very thin, but she strongly wanted to proceed with her own tissue. So for this, we actually did 2 flaps on each side. And this gets into a nuance of like where to take from and what's desired. And I spoke with her about all her options. She wanted to stay away from her legs. She wanted to use her lower abdomen, even though she didn't have much to donate there. But we were able to use that in combination with tissue from her back. to provide for the reconstruction. This is how she showed up to my office. She had recently had the mastectomies and tissue expander placement, and we kept these for several months while she sort of went through other treatment. And then she came back, and this is actually the balance of two flaps, so one from the abdomen, one from the back, which provide her with actually a fairly good and fairly sizable breast reconstruction. Actually, she stated larger than she had started. This is another similar situation, a patient who's very thin, doesn't have much to donate, but very strongly wants to proceed with autologous or reconstruction using her own tissue. And this is, again, where as a plastic surgeon, I don't want to force the hand of the patient if I don't have to. This, in many cases, people's practices, they would certainly push towards doing implant-based reconstruction because, in all honesty, it's much easier, much more straightforward for this patient, but she strongly wanted to use her own tissue. So I had to take flaps from two different locations, and that included the abdomen and then from the thighs. So this is her starting out, and you can see she's moderate size in the breast, but certainly very thin otherwise. We took tissue from the lower abdomen, actually did an incision that actually lifted her breast a little bit. You can see the two colorations in the nipple, in the areola replacement region. One is from the thigh region, which is the lower one, and one is from the abdomen, and that's the upper one. But together they make a very nice breast shape and a very, very nice breast volume for the patient. And ultimately, she was able to go on to tattooing and everything else to balance the situation. So it worked out very, very well for her. She was happy that we were able to combine those tissues to give her a non-implant-based reconstruction, which was her desire. This is another patient now. All these patients have had skin sparing, but again, there is nipple sparing that can be performed. And with that, we could still also perform the same operation. Here's a patient who underwent nipple sparing mastectomy. She was not big in the abdomen, but this is her preoperatively. We were able to use her tissue from the lower abdomen and provide her with, I think, a very good overall breast reconstruction. This was actually a second stage. I will often leave, and you may see this in further pictures, a little piece of skin from the area that we take it from, and that's for monitoring post-operatively. And then when they come back for any touch-up or even in the office, we could remove that skin and close the area together. And this is her pre and post-op. I'm just showing the incision from where we took the tissue from. Here's another patient, bilateral nipple sparing mastectomies. And for this patient, you'll see that the area of the skin island that we left in for monitoring, that's down below, and ultimately was able to just take that out and close it. And that actually is in an aesthetic location that gave us access for the mastectomy. And we did that so ultimately a breast lift could be performed on the patient if needed down the line. But that just shows at least the shape. And this is a soft, very natural feeling breast, similar to the pre-mastectomy breast appearance and texture. Other options, and this is what's called an S-gap or superior gluteal artery perforator flap. In other words, an area of tissue on the upper abdomen. And this is a patient that, and this is just showing a representation of it. And this is a patient that came into my office. She had previously had a left-sided reconstruction at an outside institution approximately 20 years prior, where she had breast disease on that side, and they had used what's called a standard gluteal flap with muscle on that side, and she had an excellent outcome. The patient came in now needing the right side to have mastectomy, and she still wanted to use tissue from that location, but the other gluteus. So we tried to provide her with that, and here you could see where the incision was actually very well hidden on the left side in the upper gluteal position. And this is her afterwards. Again, she had a very small, this is soon after the surgery and healing. She had a very small sort of separation of the skin, which healed in and ultimately became, a very thin line once we revised. And she ultimately underwent also nipple reconstruction. You can see the incision early on. You see what happens to it over time on the left side, but we tried to match the level on both sides. And she did very well overall with actually a good match to what she had preoperatively and gave a good balance for the other side. And she was very happy overall with this approach, and this was her desired approach. Profundal artery perforator flap. Again, this is an area taken from the thigh as another source of tissue from the medial thigh. This is a patient, again, smaller breasted, but also had very little tissue to borrow from other locations. She wanted to use from her thigh. So we took it in a transverse fashion from her by her gluteal crease. Again, you could see that little window of skin that I left in, and that's for monitoring. So I could see that the tissue is perfusing well. I could actually listen to signals on it, and we could follow it. And I shortly after this time removed that and closed it, and she just ended up with a small lateral incision on her breast on each side where they did the mastectomies from. And this is very early on, just showing where the incisions were taken from, just below the gluteal crease on both thighs. Another patient with, you could see prior surgery, prior lumpectomy, asymmetric breasts, fairly large size breasts for her overall size. She did not want to take from her abdomen, and she certainly did not have enough tissue in her abdomen alone to provide for the tissue. So she wanted to take from the thighs, which is what we did. And you could see this is her sort of second stage. She needed to loosen the nipple on the right side, and we did nipple reconstruction after the pap flaps and tattooing to give her a fairly good balance and fairly good appearance on that side, with a natural look of the nipple areola as well as the breast, and fairly good symmetry on both sides. And these are her healed incisions just below her gluteal fold bilaterally. And that's her pre and post operatively. LTAP, which is lateral thigh perforator flap. This is a patient, again, moderate breast size. She did not want to use her abdomen. She wanted to leave that as a donor site. She felt that she had more tissue in her lateral thigh region, and we were able to find blood supply and take the tissue from that location for each side, spared her nipples, and ultimately revised her. And it did a little more fat grafting superiorly, and we're able to get this appearance for her bilaterally. And these are the incisions and locations where she took it from. And she was actually very happy because we were able to reduce that area in size for her, and ultimately did liposuction, which was going to take some more tissue just to sort of fill in contour areas superiorly to help balance her bilaterally. So those are the types of things that we could do to help smooth out areas and do secondary procedures to make the breasts even look better over time as we go through the reconstructive process. And I really go as far as the patient wants to in getting these to look and feel as good as possible for them through this reconstructive process. And that's her pre and post-operatively. And actually, size-wise, she increased in size somewhat, which was part of her desire also. So advantages, I think better aesthetics is wrong to say. I think, you know, and you'll see, I think we can gain very good aesthetics from implants also, but it's the patient's own tissue. And I think it gives them a more natural feel. It's going to age with them. It's going to hang as the breasts will hang. It can gain weight when the patient gains weight and lose weight when the patient loses weight. So it acts dynamically with them. And you can get a reconstruction done in one sitting if you desire, or we could touch things up accordingly to get the best possible outcome for the patient that they want. Disadvantage is a little bit more complex surgery, takes longer operatively. A bilateral case can take 6 to 8+ hours, depending on the type of tissue used. And you have to make an incision in another location. So there's the healing that goes into that. I usually think it's around, and everyone's a little different with this, but in a bilateral case, around 3 days in the hospital. And I usually look at about 6-week recovery time in that setting. Implants, the other end of the spectrum. This is just showing a schematic of a tissue expander, which is what's called a stage reconstruction, 2 stages. A tissue expander is a flattened implant, but it allows us to fill the implant by just putting a needle into it afterwards and injecting saline. I usually try to put saline or fill the area as much as possible when we're doing the operation initially, but ultimately we need to usually fill it more till we get to the size that's desired, then we replace for a regular implant. In this schematic, it's showing the implant going under the muscle, which almost always was how we did it, or at least I used to do it. I don't put it in under the muscle as often. In fact, 80% of the time I'll put it on top of the muscle and reserve for going under the muscle for very specific situations. You could do this in 1 or 2 settings. You could also put an implant directly in if you have the right skin envelope, or you have enough skin to put in the desired size of implant that will work. And there's different methods of holding that in place using various forms of material or biologics to help hold it in place along with or without the muscle. But all of these could be offered depending on the type of mastectomy and the type of reconstruction that the patient wants. Stage 1, if you're doing a stage operation, is the placement of the tissue expanders immediately after the mastectomy. And it could be done also in a delayed fashion if someone's already had a mastectomy. The second stage usually is around 4 to 8 weeks or so afterwards, which is where we begin filling of the implant. And we'll do this in the office to the desired size of the patient. And third is bring the patient back to the operating room, taking out that expander and putting a regular implant back in. And that implant could be saline or silicone. Most people will get silicone nowadays just because of texture and appearance with less risk of rippling, but saline is still an option if the patient strongly desires that. The tissue expander is fairly quick. It adds around, let's say, 30 minutes or so to the operation. And if you're going above the muscle, maybe even quicker. We then close everything and fill the implant usually to a safe amount in the operating room. The risks of the operation aren't necessarily big, but it's dealing with the implant, which there can be a mechanical failure, or what we call a leak. And in saline, that would just deflate. In silicone, it would kind of sit there until you realized it. And then usually we have to replace that or exchange it. You could also have, patients can have what's called capsular contracture, which is tightening and thickening, which could cause a deformity or even rarely, but sometimes discomfort. All of the implants are FDA approved nowadays, saline and silicone. There was some history of silicone, but that was really from FDA approval side. So they're all technically safe. That's a whole other discussion, but the choice will be the patients as to what they want to use or do. But we'll get to some pictures. This is a patient right-sided breast skin sparing mastectomy. Ultimately, she had nipple reconstruction, I think also radiation, and she wanted actually to be larger in size. And this was her starting out. So again, she needed right-sided mastectomy for advanced breast disease, had previous surgery on that side, and was coming for essentially skin sparing. And this is the expander in place. And she did have radiation historically to that side, but we were able to get enough expansion and inflation to actually give her some more volume on that side. We ultimately took her for exchange of the implant and a breast augmentation on the left side to give her a larger size bilaterally and fairly good balance. Then she had nipple reconstruction on that side for an overall balance for both sides, and then went on to nipple reconstruction. So again, you can operate on both sides based off of the desire of the patient. And some patients, they want to lift on the other side. Some patients want increase of volume on the other side. And as you can see, she got to have this reconstruction without any other incisions in any other parts of her body. So for this, it worked very well for her overall. And this is her pre and post-op showing her final outcome. This is a patient with bilateral, again, skin sparing mastectomies and staged implant reconstruction. She had right-sided disease, but opted for bilateral mastectomies, also a family history. And this is her afterwards with skin sparing, tissue expanders that were placed, implants replacing it to give her a larger size as per her desire. She ultimately had nipple reconstruction and nipple areolar tattooing. And this is her pre and post-operatively. Here's another patient with bilateral nipple sparing mastectomies, but also had a staged implant reconstruction, again, desiring larger breast size. So instead of going and putting implants directly in, we could, when you're doing the mastectomy, I don't feel comfortable in over expanding it because I think it puts too much strain on the tissues. So we'll put a tissue expander in, inflate that, and then she's able to go to a slightly larger size as per her desire. And she was able to spare her nipples through nipple sparing surgery, and gave her an overall desire and good appearance. And actually, this is just the lateral, and you could see preoperatively, postoperatively, the balance between the breasts. Here's another patient who's undergoing bilateral nipple sparing mastectomies and also desired slightly larger size. And you can see the ultimate outcome with implant placement after inflation. I don't necessarily choose the size, just as long as it's from my own self, as long as it's within the appropriate size of the chest wall. I'm not trying to make anyone, or do I recommend making them look cartoonish in any way. I want them to fit in with their chest wall, and I really go with the desire of the patient and ultimately inflate to the desire of the patient outside of those limits. But here's another, this she certainly could have used abdominal tissue, but she didn't want an incision down there. And we were able to do this with implants alone. Not all of them have to be, there's not actually another patient. What happened, she wanted to have also bilateral implants. She had initially nipple sparing surgery. She wanted to have larger size, so we did tissue expanders in the time period where she had her mastectomies. And after the tissue expanders, it was noted on final pathology specimens that she needed to have a nipple removed because there was some cells noted just underneath it. So she had while she came back, before she came back for implant exchange, we did a nipple excision, and then ultimately I did a nipple reconstruction and implant exchange. So this is her, and she actually, that side on the right, had nipple partial removal and nipple reconstruction, and then down the line we did tattooing to help balance her and give her a normal appearance. And she actually got tattooing on the left side to give her a fairly symmetric bilateral coloration to her areola. This is a patient who went bilateral nipple sparing, but we did a single stage reconstruction on her. And you can see her preoperatively. She underwent bilateral mastectomies, and this is her after what's called direct to implant placement. So I was able to put these implants immediately in when she had the mastectomy. She had excellent what we call mastectomy flaps, and this tissue looked good, and I was able to give her a fairly symmetric and fairly similar match to what she was preoperatively. And you can see the balance of her, and this is pre and post-op. Another patient, bilateral mastectomies, nipple sparing through another incision, which were lateral incisions. They were able to spare the nipple, and I was able to do a single stage implant reconstruction on her using that approach with a very good and symmetric outcome, and actually maybe slightly larger than she started out with, but using the skin envelope fairly symmetrically. Lastly, is combination reconstruction. This is with, for the most part, latissimus and an implant. Why do this? This used to be actually one of the more popular reconstructions when people were doing more formal, larger mastectomies. In other words, taking a lot of skin. And, only 30 or so years ago was the evolution of skin sparing mastectomies. Otherwise, people were getting some form of a radical based mastectomy where 2 hand breadths of tissue where skin was removed, and basically the skin was closed tightly. What this would do would take tissue from the back, which was rotated to the front, provide for a nice skin envelope, and then underneath an implant could be placed if desired. If the patient had enough tissue in the back, which is not often enough, it could be enough for doing the reconstruction. In this situation, I usually, it's kind of an in-between operation. I think it takes a little bit, certainly more longer time for recovery than just an implant itself, which I think is about 3 to 4 weeks. I usually tell people this is around 4 to 6 weeks in recovery, usually a day or two in the hospital. And then after that, the recovery is at home, but it is isolated to the back and breast. So the core abdomen is left alone and legs are fine. So I think the recovery is a little bit different than when we do what's called free flaps from other parts of the abdomen or thighs. This is a little bit less done because now patients are having more nipple sparing type surgeries or skin sparing surgeries. So this isn't used as often, but it does have a role, and certainly has a role for secondary type reconstructions, where if someone's missing tissue, it can provide extra tissue, or if they had an issue with an implant, let's say, and it needed to be removed, or you're trying to salvage an implant that's been radiated and tightened and thinning, it's a tremendously good flap for that type of reconstruction. This is just showing a schematic of where you can position the skin in any orientation on the back that you want. And I usually choose in this direction. You could choose transversely or in another in the medial oblique region and rotate that over into the breast to replace skin if taken. And the muscle sort of is an excellent coverage for the implant. I can't tell you that I have many patients that I could think of that have had issues with taking this muscle, and I use this muscle even for other types of reconstruction. This is a patient just after bilateral immediate latissimus flaps with implants with a fairly good reconstruction. And this is just showing the locations of where you could take the skin and muscle from. Here's another patient with a right-sided mastectomy, fairly fresh out from this. And you can see that it provided her with a single stage reconstruction with good skin coverage and an implant underneath with fairly good balance to the lateral side. And another patient who's undergoing right-sided mastectomy, and she chose to do this. She needed to have a fair amount of skin out around the nipple areola. I was able to take the muscle, this is just showing where the muscle's taken from, and rotate that from the back into the front. The skin's provided for covering of the defect. And this is her immediately in the operating room. That's just showing a saline implant being filled. And this is her in the, I think in 2 months post-op, showing a good contour, a good balance for that side and lateral. And this is the other previous patient just showing the resection, and this is reconstruction. And this is even 2.5 years out, and she even needed radiation, which actually held up fairly well. The reconstruction actually held up fairly well to the radiation. The other side is a little bit more ptotic than the right side, but certainly that could be addressed. She had no interest in doing that. She looked good in clothes, bra, and even I think outside of clothes, she felt fairly balanced and comfortable with her appearance. Another patient, just different body habitus, showing the left-sided latissimus flap, giving a very generous or good amount of tissue for the reconstruction, and with a single stage implant placed into that side. So this can also give a very good reconstruction overall. I'd like to thank you. This, I hope, gave you a sort of a sense of the types of reconstructions we can do, and I would leave this open for questions, which I think are upcoming. Thanks.
Thank you so much, Dr. Levine. Okay, let's get to some questions. All right. Let's say this person had radiation and a mastectomy, and they are unhappy with their reconstruction results. What type of new procedures would be on the horizon?
That's a great question. So, again, like I said to you before early on, every situation depends. I found, and this is actually what the part I like, is like there's no two cases that are exactly the same. And everyone's different in what their desires are, and everyone's different in what they have to work with. However, I think in situations where radiation is involved, I respect radiation tremendously. radiation is used to help fight the cancer and is a very important tool in breast cancer and other cancers in sort of obtaining cure. But it will change the tissues to some extent. So it could tighten them. It could shrink a normal breast to a smaller size. So it gives asymmetry. So in patients that come in, let's say that they haven't had a surgery and they've had radiation, we'll go through various options. If the skin is very poor, then I think replacement of it is what I think would be recommended. So I would choose one of the options or go through the various options of using your own tissue, whether from the abdomen, whether from the thigh, whether from the buttock, whether it's a combination. There's some patients who have so much devastating injury from the mastectomy, from tissue loss, from advanced disease, that they may even require multiple flaps to be utilized. And I've done that on a number of occasions, but we could obtain very good outcomes and very good results doing that. Or we could do something that's a combination, replace some of the skin and then put an implant in. Or if the patient's not happy because it's kind of tighter than the other side, we could still use the implant and maybe open up that envelope a little bit more with their own tissue. So there's a lot of different options that we could utilize when faced with that. So if someone's going through that, what I always tell them, it's certainly worth it an ask. I mean, you should ask. It's not wrong to ask. I mean, I think people sit around and say, well, this is the lot I have, and there's probably nothing that could be due to it, or am I being frivolous in asking for it, or because it's really, I shouldn't be worried about that. I think it's reasonable for someone to ask. I think it's important for someone to want to know, can this be made better? Can I look better? Can I look better and feel better if that's what's bothering you? And I think that's an important question to ask. And many times we can.
I love that you said that. It gives some of the power back for the patient, because there's so much that can feel out of control. And it's our patient right to ask those kind of questions. Here's another question. Are there certain plastic surgeons who will do a fat transfer as the sole method of reconstruction if a patient is only wanting a very slight curve, thinking of like essentially a AAA cup size or smaller?
That's a great question. That's the graduate level course in this. Yes, absolutely. So I think I showed maybe a few patients in there. And actually there's probably more, and some of the patients I showed probably even may have went on to other surgeries in getting sort of contouring. Okay, so we do what's called fat grafting not infrequently, where we'll take some liposuction from another part of the body. What you see when I talk about using your own tissue, that's a chunk of tissue that we're taking with a blood supply.
Mm-hmm.
And we're able to take that because that blood supply keeps that tissue alive and transplant it to the region. We could also do what's called grafting. And grafting means you're taking out tissue, which is basically cells of tissue, and you're placing it somewhere. It's very similar to doing a skin graft, where you take a shave of skin and you put it on a piece of the body, and then it grows blood vessels into it. And you could do that with fat. You could take it, if you put it in little strings in different planes, you could actually build up tissue, and then over time, the body will grow and keep those cells alive to add to it. But you can't do that much. You can do a little bit, and you could add to it over time. Because when you put too much in, the body can't revascularize it, so it'll just absorb it. So I usually tell patients maybe 50% of what we'll put in will stay. But, if you put in 200 cc's and you get 100 cc's, that's pretty good, especially if you're just doing contouring. You can do that for patients as the sole type of reconstruction. Yes, I think that not every plastic surgeon does that with frequency, but some do it with a lot of frequency, and some do it with, as just part of their practice. It does, if you're looking, and they mentioned being a very small A, so yeah, they may need 1 or 2 goes at it. If someone wants to be bigger, they may need even up to 6 or 7, I'd say, procedures to be able to get enough compilation of fat to build up to give them the breast reconstruction they want.
Wow.
So that does exist. But that group, I think, is, certainly more specific in who does that.
Got it. Got it. Let's see. Is it possible for a patient to have one stage implant reconstruction, and after a few years do an how do you say that, the
Autologous.
yes, reconstruction? Can they have that a few years after?
Absolutely. I made reference to it during that, in that, and I'm faced with this all the time for various reasons, but let's say just strictly someone has an implant-based reconstruction. Even let's say that it's a very good implant reconstruction. It looks good. Everything appears good. It's remained soft. There's no real issues, but they're not comfortable, or they don't like it, or they don't feel comfortable with, whatever the reason is. You can convert that to an autologous or using your own tissue reconstruction. Done that many times for patients. Often it's for patients that are having some, let's say, issues with the prior implant reconstruction in some way. But you could just do it because that's what feels better for you. And ultimately that could be changed. Many times we'll do that. And I see this all the time, where we know a patient is going to need to have radiation, and we may make the recommendation, instead of using your own tissue up front, because once you radiate afterwards, once you have the radiation, you will change the reconstruction. In other words, you might have a nice, soft, supple reconstruction, then radiate it, and it'll lift it up and change it to some degree. So many times we'll say, well, maybe get an expander reconstruction to start, and then we'll come back and we could do your own tissue later on. So there's a lot of different directions that can go, but all of those opportunities and options are open for someone. Yes.
So this is another great question. What do you recommend, or what do you say to patients who are, in the age range of 20s to 30s, who can have a skin sparing mastectomy, and is planning on pregnancy later in life? What do you say to patients who want that?
Great question. And, again, this is one of those things where it's such a specific discussion with a patient. So that's where the consultation is so varied, right?
Mhm.
I'll be going over and, dealing with those questions or issues. Now, all that being said, I have had patients who have done, let's say, breast reconstruction, or let's say a paniculectomy or tummy tuck, and they've then gotten pregnant.
Mhm.
It does not, to me, I'm saying this from my own and how I treat my own patients, it does not preclude you from getting pregnant or having a pregnancy. The thing I tell them, though, is it may, someone who maybe hasn't gotten pregnant, they may not have much redundancy or excess of tissue. So then you go take it out, you tighten it more. So it clearly will stretch that tissue a little bit more. So if someone knows that they want to have get pregnant, they don't have that significant tissue availability, it may make sense then to do something like an implant-based reconstruction, or use tissue that's not from the abdomen and use from another location. And there were several patients in there that I showed, one that had the lateral thigh flap, and another one that she already had several kids, but wanted another one, and she used from a medial thigh. So sometimes you could still do that, use your own tissue, but not from the abdomen. So there's various ways to go, but it shouldn't stop someone from getting pregnant specifically. I'll just say that.
Okay. This is a question I've also experienced this too. For many, it seems that there can be a loss of sensation. And that's one of our questions is, why does that happen? Is it permanent? I know even for my own surgeries, I am absolutely numb on my outer left side. Why does that happen? And what do you tell patients about it?
Great. Well, in all honesty, a lot of that's told probably by the oncologic surgeon, but in truth, I do deal with it all the time. For the most part, a lot of people will gain back some sensation. Some can became back a lot of sensation. I've seen every piece of the spectrum under there. When doing a mastectomy, and let's say if doing an axilla, there are the nerves that come up directly in the mastectomy directly up into the nipple areola complex from the interspaces. In other words, is like the ribs, and within those interspaces, nerves sort of come up and then feed up to the nipple and areola and the surrounding skin. A lot of those need to be taken. They're not even visible. They're just part within the breast tissue. So when you take them out, there's going to be numbness, as almost any surgery when you are removing tissue. You're going to be taking the local nerves that are around there. Not necessarily the main deep nerve, but the local nerves that feed up into the breast tissue and the skin. In the axilla or the side, many times that's related to branches that come through the axilla. So depending on what needs to be done, depending on the need of the oncologic resection, some branches of those nerves may need to be sacrificed. Even though they do actually try to spare many of them, even with doing a full axillary dissection and are able to, there may be some branches that just need to be taken because they're invested within the lymph nodes around there.
Mm-hmm.
But, again, a lot of it comes back in the skin. There is discussion, and there are people, and I wouldn't say everyone, there are some people who are doing reasonable work and looking at trying to re-neurotize the area using nerve grafting and stuff like that. That's, I think, in its infancy, and I don't think the data is out there to give yet a definitive on that, but there is a thought process, because obviously I think we've gotten to a point where we could maybe make the breast look good. We could hopefully make it feel good by whatever mechanism, but in other words, as far as texture, but now people are looking to the next level and looking at sensation. So that's out there, and we're trying, and we're looking at options related to that.
I do hear that a lot, and it's so difficult when you do lose that sensation. So you did kind of allude to this in one of your slides in talking about like what kind of changes can one expect to the breast, I guess, depending on the type of surgery over time. As we age, or what if it's like a really big weight gain, or all of a sudden you lose a ton of weight? What do you say to patients who experience?
That's a great question. So I know that time is a little short, but that's the good or bad thing about the reconstruction you're choosing, right? An implant-based reconstruction. Once that implant goes in, if we put it in immediately, it'll come down, it'll slide into the pocket. But eventually it forms what's called a capsule. Every implant, no matter where in the body it is, will form what's called a capsule, which is some scar tissue, very normal and very natural. That will stick the implant into position. So all of a sudden that the implant reconstruction will be fixed and will remain potentially youthful in that way. The autologous, or using your own tissue, over time may come down because it's now acting more like a normal breast because it's softer, more pliable tissue. That, I think, is a good thing, but some people may look at it as not a great thing. It just depends. In the weight gain, the fat has the memory from where you took it from. So if you gain weight of significance, it can increase in size. If you lose weight, like in bariatric surgery, it could deflate. And all of that could be treated with secondary procedures if it's deemed to be not satisfactory, however, for the patient. So I wouldn't let that deter someone. I would just take it into account that it's part of the balancing process that we would go through in treating you surgically and otherwise.
Well, Dr. Levine, this has been so insightful, and I love the diversity of images that you showed us today. Greatly appreciate your time. You're amazing. Oh, look at that, getting some love from the audience. Yes, claps, hearts, yes. So again, thank you so much, Dr. Levine, for a supremely informative program. And thank you to all the participants for your great questions. We greatly appreciate it. So just know that we will have this presentation and recording available on our website on sharecancersupport.org in 1 to 2 weeks. So you will get an email saying when it's ready. And make sure to check out SHARE's website for upcoming educational programs and our support groups. And don't forget, follow us on social media as well and listen to our podcast. Please take a moment. As soon as we're done with this webinar, a survey will pop up. Please take it. That's how we figure out what topics or what else you want to know, and make these programs for you. And all surveys are anonymous. So again, Dr. Levine, thank you. And everyone, we'll see you soon. This concludes our webinar. Bye.
Bye.